All right, normal cardiac function. So these are concepts that the link wasn't working for Slack. Okay, I can fix that. Thanks, Elsa. Thanks for bringing that up. Cardiac blood flow. I really need you to be able to understand how the blood flow moves around in your body, because you will have a lot less trouble remembering signs and symptoms if you know the path of blood flow. Let me see if I put my favorite. Oh, I did. Okay. This PowerPoint has an updated slide of scribble that I did, and I think I'm funny, so I'm going to keep it. Anyway, what we're going to do is we're separating this heart. I need you to separate the heart in your brain into two sides. Okay, two separate pumps, a right side pump and a left side pump. The heart is not one pump, it's actually two. And separating the heart in your mind will really help you process the signs and symptoms that we see when the heart goes bad. And remember, it's just a pump. In fact, you guys did the harder stuff last semester. The kidney and the liver are much more complex than the heart. The heart is just a pump. And it gets so much, it's just such a drama queen, man. I've been a cardiac nurse forever. But this heart definitely is a drama queen. It gets way more attention than it deserves. It doesn't really have any functions other than to pump. And God, the liver and the kidney have so many amazing functions. But let's talk about how we flow through this heart. Deoxygenated blood. So I usually color code the heart. The right side of the heart is blue. The left side of the heart is red, because deoxygenated blood is in the right side of the heart and oxygenated blood is in the left side of the heart. You do and you will need to know which valves are on which side of the heart. Let me show you again. And I have multiple pictures. Find one that sits with you and that you love. This is I like this picture too. This is the heart's right heart, left heart, lungs and body in between the two hearts. The body returns to the right heart, and then the right heart sends it to the lung circulation. It gets oxygenated there, and then it goes to the left heart. So just keep that two pump concept in mind. And this is my my scribble scrabble, but I think this might be helpful for you guys in seeing the flow. I took the city of Phoenix here, and I turned it kind of into our body here. And if we think about the right heart and the left heart being separated apart with the lungs get to live up in Scottsdale because they're kind of, we got the right heart, the left heart, and the lungs in between. So you can see, if you're thinking of this as a highway, let's just pretend that the city of Phoenix got turned into our body, and we only have the red highway and the black highway, okay? The 17 and the 10 have become our GI tract, and we have our blood circulation going around that 101, 202 complex there. We have our body circulation here. So you can only travel on those two highways. That's it. So you are a little cell living out in Queen Creek. You are dependent on delivery service. You're not on the highway. You don't have a car. Okay, you're dependent on delivery service, and these delivery vans only run around on the highways. This is a dystopian society here. The deliveries will come to you off the highway. So if you are a little cell out in the Queen Creek area, you are dependent on delivery vans that will travel around the city. So let's say that we have this this highway system here in red that the delivery vans travel around on. The left heart goes down. Let's put in this picture here, the left heart there's an accident here, the left heart is not working. So this area is out, under construction, accident. Where are we backing up now? If this is now closed off because of an accident, where are all the delivery vans getting backed up? They are backing up this way into the lungs. This is where the traffic is backing up. The traffic is backing up, and then it could get bad enough that it backs up through to the right heart. So I do like looking at that because it will tell you that if you are having trouble with your left heart, we are going to be concerned with backup into the lungs. Let's say that our right heart, there's an accident here in the right heart. Right heart goes down. Where do all the delivery vans back up? Out this way into the liver and the body system. So yes, it will eventually back up because our blood is a big circle circulation, but we can see the next, and then of course the delivery vans will start getting off the highway and going around a bit. It'll take a lot longer. So we can kind of see right now what our signs and symptoms are going to look like when these things go down. So I do like looking at something along this lines. Like I said, I got a big kick out of drawing this. You guys can find it funny or not, or use one of the more serious diagrams. But I really do like thinking of the body as if we look at this one, this is really saying the same thing. If your left heart doesn't work, let me draw my little picture here. If the left heart, the left ventricle is not working, we are going to back up into our pulmonary circulation. If our right heart isn't working, we're going to back up to the body. So I want you to really get that concept in your brain because it will make you, I just despise memorizing lists. You know me, I can't memorize a thing. So anyway, there's those. I obviously thought I was really funny here. I made a little drawing last semester. I don't know if it will play, but it shows the little trip of the blood cells through here. So yeah, I think it does play. Let's see if there's no sound or anything to it, but you get to watch these little blue red blood cells travel through, and I kind of talk about the anatomy. You know, we have the anatomy down there. The red blood, the blood cells go through the right atrium, they go through the valve, they get into the ventricle, they go to the lungs, they turn red. It's adorable, it's great. Good viewing, but again, just to recognize the anatomy and to understand that the heart is two hearts, and when we have problems with it, there's differences. So anyway, you can watch that little video. One of these will catch your eye and get this concept in your brain, and that's it. So cardiac blood flow, right heart, lungs, left heart. Go through. It's stuck. One to play. Okay. So I came up with a little thing for you to remember which valves are on which side, because again, you don't need to memorize what's going to happen if one of these valves goes down if you know which side of the heart the valve is on. So I came up with TP-MA. TP-MA is a, kind of like what somebody would scream out if you're running out of toilet paper in the bathroom. But TP is on the right side of the heart, and MA is on the left side of the heart. You have your tricuspid and your pulmonary valves on the right side of the heart, and your mitral and aortic valves on the left side of the heart. So once you've blown your heart into two pumps, and you have a right side heart and a left side heart, and you know that TP is on your right side, you know that tricuspid pulmonary is on the right side. If we have any problems with those valves, you're going to have right heart problems. If you have a problem with your mitral or aortic, you're going to have left heart problems. So TP-MA will help you sort out which side of the heart your valves are on. So yeah, just imagine someone screaming out TP-MA, and you will always have, and in fact, I almost did this. I did this for myself for a, just to help myself through nursing school. I figured out TP-MA, and I was watching a cardiac surgery with a cardiac surgeon, and he was doing a valve replacement, and he was asking, he was doing, I think he was doing a mitral valve replacement, and he goes, well, which side of the heart is the mitral valve on? And I said, TP-MA, and he just looks at me, and he's like, okay. And I'm like, the left side, the left side. Anyway, it was embarrassing. But if you remember that, you will always know which side it's on, and you'll be able to figure out your signs and your symptoms from there. So here's your heart valves. We will be using these heart valves. They will come into play with abnormal heart sounds in a little bit. But really, if you have, and I color-coded these, remember the right side of the heart is blue because it's deoxygenated blood. The left side of the heart is red because it's oxygenated or post-lung side. So TP, tricuspid pulmonary, are on the right. MA, mitral, and aortic are on your left. But the first ones listed are, so if we're looking at your little heart here, we have two kinds of valves. We have the valves that are in between we've got the atrium and the ventricle. They're well known as AV valves, which is amazing because they're aortic. They are between the atrium and the ventricle, so they're AV valves. Your AV valves are the ones that control flow from your atrium to your ventricle. They're the first ones listed. So in TP, the top one, the T is your AV valve, and the M is your AV valve. Does that make sense? So we have your tricuspid and your mitral are the ones in between your atrium and your ventricle. Then we have our outflow valves, which are great because they're named for the place they outflow to. So on the right side, we have our pulmonary valve. The pulmonary valve goes to the lungs. Yay! On the right side, we're before the lungs, so our pulmonary valve is letting blood flow to the lungs. And then on the left side, we have our aortic valve, which is kind of buried in the back corner here. We have our aortic valve, which is now letting from the left ventricle out to the aorta, which the aorta is the main vessel out to the body. So our outflow valves are named for the places they go. So we have our pulmonary and our aortic valve are outflow valves, and then the other two are AV valves. So our tricuspid and our mitral, our tricuspid and our mitral are in between our atrium and our ventricle. You do need to know this somewhere along the line. So this slide, if you get them mixed up, TP-MA only helps you know which side is right and which ones are on the left. Which one's right, which one's left. It doesn't tell you which ones are AV valves or outflow valves. But I do like that the outflow valves are named where they're supposed to go. So pulmonary, aortic are outflow valves, and the other two, tricuspid and mitral, are AV valves. So this will make sense and will start coming together. The sounds we hear, lub-dub, are the sounds of valves closing. We only are supposed to hear valves when they close. Otherwise, valves don't make any noise. So lub-dub is the sound of valves snapping shut. And what happens with lub is your AV valves close, and that is the end of diastole. So diastole is when the ventricles are filling. They call it rest. It's not really rest. The heart never rests, ever, ever, ever. But they call it rest because the ventricles are filling. Now, the atrium actually contract during diastole. They are squeezing blood into the ventricles, but we call it rest because the ventricles are filling. The ventricles are the star of the show. They're the ones that pump the blood the strongest. So we will call it rest when the ventricles are not actively pumping. So diastole is when the ventricles are not actively pumping. So in diastole, you can see on our picture here, this is where in diastole the ventricles are starting to get full. When they're ready to eject, those ventricles are full and they need to burp this stuff out. When they're ready to eject, the AV valves will close, meaning that the atrium is now no longer open and dumping into the ventricle. The AV valves close. And when the AV valves close, that is the end of diastole, and now those ventricles can squeeze out the blood. So ventricles are like a sponge. When you soak a ton of fluid or blood into that ventricle, and now they squeeze out. They squeeze out during systole, which is when they're ejecting. So when your AV valves close, your outflow valves open. So when your AV valves close here, you can see here we just did lub, the AV valves close and the outflow valves open because we are about to eject blood out. If the outflow valves are closed, blood can't eject out to where it needs to go. And during systole is the ejecting time. The ventricles are squeezing that blood out to the lungs and to the body. So during systole, we have outflow valves are open, the AV valves are closed. The sets are always combined beautifully. It's a beautiful little ballet going on that when lub happens, AV valves shut, the other valves open. We don't hear the other valves open, but each set will open and shut together. So at the end of systole, when they're done ejecting, which valves will close? Well, you guys are reading it, right? It's the pulmonary and the aortic. The outflow valves close. We're done ejecting. The outflow valves close up, and we then open the AV valves so that we can fill up. Any questions on what is happening in the heart during diastole and systole? Diastole is rest because the ventricles are filling, so the AV valves are open, and the outflow valves are closed so that the ventricles can fill. And then during systole, the outflow valves are open and the AV valves are closed. So another concept that will come into play when we're talking about abnormal heart sounds. So the only thing we should be hearing is lub-dub, lub-dub. And those are the sounds of the different valves closing. All right, no questions. You're like, I got this. You're cardiac heroes now. Let me go to the next screen. Come on. Go to the next screen. Okay. Some more concepts. And again, these come into play. Preload is the amount of blood returning to the heart. The amount of venous blood returning to the heart, pre-heart, preload. This is the amount of fluid that the heart basically has to deal with, the amount of fluid that the heart has to pump around. So if the volume of the fluid the heart has to pump around is too little, then the heart works really hard to kind of circulate around a small amount of blood. If there's too much, the heart has to work really hard to pump around a lot of blood. So both of them, either a low level of fluid or a high level of fluid, will cause an increased heart rate. Any ideas? Maybe don't go forward on the slide just yet in your papers. Any ideas of how we're going to assess preload? Any thoughts? Everybody's like, no, just go forward. Heart rate. Well, so we could look at heart rate, but unfortunately, heart rate doesn't tell us whether it's too little or too much fluid. Both of them give you increased heart rate. So we're going to look for signs of too much fluid, and I see JVD, edema, hydration status, edema, ejection fraction. Oh, look at you guys. You guys are so good. So preload is going to be just fluid volume status. So the things that give us measurements of preload is JVD. So yay for bringing up JVD, and edema. If we have too much fluid circulating around, we really can't see that. It's hard to see. If there's too much fluid circulating around, we will get fluid back up into the biggest vein that's dumping back into the heart, which is your jugular vein. That's the one draining out of your brain into your heart. And that is the first vein we will see starting to get backed up. So that's why we look for jugular venous distension and peripheral edema. And peripheral edema means that if the blood vessels are too logged full of fluid, we leak out. Okay, when the pressure's too high in the veins, it will leak out. And it leaks out at the weakest capillary points. And the weakest capillary points are areas that are very thin and easy to leak into, which are your capillaries in your extremities and your capillaries in your lungs. Those are our weakest, those are our leaky spots. And the rest of our vessels all over our body, it usually keeps blood. It's part of the highway. It's not where the delivery trucks get off. But our delivery trucks get off to make deliveries at the capillary sections. So when there's a lot of traffic, they're going to get off onto the side roads, and the side roads are in the extremities and in the lungs. Those are where our capillaries are the weakest and prone to leaking. And so that's where we're going to see fluid, when the pressure gets high in the system, leak out. So if we have too much preload, too much fluid circulating around, the highway cannot handle all this fluid, things have got to get off. It's going to get off into edema, and it will cause peripheral edema. Too little, very hard to see when we don't have enough blood flow circulating around, but you will see dry mucous membranes, because obviously if you don't have a lot of blood flow running around, you don't have a lot of fluid in your system. You may have dry mucous membranes, poor urine output, because your body's trying to hold on to it. Someone said low BP. So I'm going to tell you that blood pressure and heart rate are probably one of the worst ways to figure out what's going on with your heart. Isn't that terrible? Blood pressure and heart rate are terrible because your body is doing so many maneuvers to keep your blood pressure right, that actually if you have a low blood pressure, you could be fluid overloaded, you could be fluid overloaded or fluid depleted. Blood pressure is not a measure of your volume status. Isn't that terrible? Because if you have a bad heart, you could have a ton of volume, but it doesn't translate to pressure actually being pumped out. So you can have fluid overload and have low blood pressure. So I'm going to move you away from looking at heart rate and blood pressure to assess your heart, because unfortunately the heart can be failing and have a normal or a high or a low heart rate. So I would like you to just stop right now and get rid of heart rate and blood pressure as like, oh, my heart rate is high, I have too much fluid. Because your heart rate will be high if you have too little fluid too. So get rid of heart rate, get rid of blood pressure, as much as we want to use them. And I will just tell you, after 20 years of taking care of hearts, we don't use them. We're looking at other signs and symptoms to tell us if our heart is failing, because the heart will do amazing things to keep its blood pressure up. Your body will do amazing things to keep its blood pressure up. And I have seen plenty of fluid overloaded patients with a low blood pressure because the fluid's not in the blood vessels, it's in the tissues. So we really want to look at, is our fluid in the proper place? If we have too much fluid that it is leaking out, you will see JVD or peripheral edema. So if you ever have peripheral edema, I want you to think, I've got a lot of preload. I've got a lot of fluid, and for some reason the heart's not dealing with it. The fluid's not in the right place when you have peripheral edema. And too little, I want you to really start looking at the fact that we need to see moist mucous membranes. That will tell us that we have enough fluid getting to the proper places. And also our urine output. As long as our kidneys are functional, if we have adequate fluid, we should have adequate urine output. Now, of course, this goes away with our renal failure cardiac patients, but we're going to use urine output before we use blood pressure or heart rate. Okay, that's a hard concept for a lot of nursing students to get through, but one of them, what did we call it? One of the intensivists called the Foley catheter a hemodynamic device, because he goes, why would you need invasive lines when you have a catheter that's draining out your urine output right there? If you have adequate urine output, you've got adequate blood volume. And so he would refuse to put in IV lines because he's like, you've got one. It's called a Foley. And if you stop putting out urine, then we'll try to figure out what's going on. But while you're putting out good urine, I'm happy. So think of it, we called it the Euro Swan, because they used to call PA catheters, the ones that we would put in to measure the heart. They were called Swan-Ganz catheters, the PA catheters. And so he would say, no, you have a Euro Swan, meaning you have a Foley in. And would say, no, I'm not putting in invasive lines. I will look further when you stop having urine output. So if you have too little volume, your urine output will drop. If you have too much volume, you'll have a good amount of urine output, or you'll have edema. So some concepts on preload. Preload is the amount of volume circulating around in the system. So there's, a couple things in case you don't know anything about venous distension or extremity edema. Just kind of refresh your assessments, because these are our preload assessments. I would want you to adequately measure them, and that's why we're always grading our edema, because we can tell if our preload problem is getting worse or better based on the amount of edema that we have. Jugular venous distension, again, if your patient is laying flat, they're probably going to have jugular venous distension. We can only say that you have jugular venous distension if you're sitting up at 45 degrees or higher. If I'm laying flat, I might have jugular venous distension. We have to be, this is meaning that there's backup even when gravity's there to help blood flow. So just some remembering. And let's talk a little bit about, so these are the easy to assess. And then we have an advanced assessment, which is an invasive line. And an invasive line that measures your central venous pressure will help us measure our preload. We will talk about all the different hemodynamic things here when we talk about, I think they're in the, are they in the heart failure lecture? I don't remember where I put the hemodynamics, but central venous pressure we can do in any central line. We hook up a pressure reading to any central line. It could be a PICC line. It can be an IV in the neck or the subclavian. If you hook up a pressure monitor to it, it'll read the pressure in your central venous, and that's where the catheter is ending, is in your central venous circulation right before the heart. So if we have, when we hook up this pressure, we have a normal pressure of 4 to 12, and that's a pretty big range. And so I like to explain central venous pressure, which is our invasive measurement of preload. Our non-invasive measurements of preload are edema and JVD and urine output. Our invasive measurements, so let's say we stop putting out urine output, or our patient has renal failure, and now we are having a hard time figuring out, are we fluid overloaded? Are we not? We don't know. We can hook up a pressure line to our central line and read a pressure. So normal is 4 to 12 because we live anywhere in that range. And so I put it to a gas gauge that if you are empty, if your tank is empty, or you don't have a lot of blood volume running around, maybe the volume's in the tissues, maybe you don't have any anywhere, maybe you're just massively dehydrated, your CVP will be 0 to 4. That means your tank is running on empty. 4, now we said normal is 4 to 12, but we live in certain levels of hydration depending on how much we're drinking during the day. Right now my CVP is probably 4 to 5 because I haven't drank all my coffee yet. I haven't started drinking my hydros. I just crawled out of bed about an hour ago. So my CVP is probably a little low till I start ramping up that fluid intake. Once I ramp up my fluid intake, my CVP will go up. And that's why the normal range is 4 to 12. We kind of live throughout the day with our tank half full or our tank full, depending on how much we're drinking. Most of us don't go over 12 because we will pee it out if we have too much fluid. So if you've drank 6 hydros of water, you're going to pee it out. You're going to keep your CVP around 12. But if we have patients with CVPs greater than 12, that means they are really pushing a lot of fluid around. There's a lot of fluid in that blood vessel that they are pushing around. So I like this gas tank analogy to help you figure out where in this range your CVP is. If I tell you on a test question that your patient has a CVP of 20, I want you to think, dude, that guy is super fluid overloaded. There's a lot of preload, a lot of fluid for that heart to deal with. If your CVP is 1 or 2, that means that patient does not have a lot of blood flow for that heart to deal with. Both cases will cause an increased heart rate. But it's very important for us to know because we'll do our treatments based on if you are fluid overloaded, we'll do a different treatment than if you are fluid deprived. Fluid deprived, we give you fluid. Fluid overloaded, we'll give you diuretics. So we will change our things based on that. So that is one number that I might give you in a test question to help you figure things out. You can have a normal fluid volume status just a adequately hydrated person. But unfortunately, this person doesn't have a good heart or doesn't have good kidneys. And they could be running a CVP of, 16. And that's not because they have too much fluid. It's just because the fluid just can't get around. So when we measure essential venous pressure, we're measuring right heart pressures, basically. The volume of fluid returning to the right heart. So you can have adequate fluid volume and a very high CVP, because if that right heart is not pushing fluid through, then it's starting to back up in that central vein, and our pressures get higher in that central vein. If we could put a pressure gauge in our arteries, that would tell us what is leaving the heart. So that's our next concept. Our preload is what is getting into the heart. Our afterload is the pressure upon leaving the heart. And this is where our blood pressure comes into play a little bit. The only thing we have to measure our arterial resistance that the heart has to pump against is your blood pressure. But I'm going to have you look at a different number, the diastolic. This is our rest pressure. So think about 120 over 80. 80 is your diastolic, correct? That is the pressure that your heart has to pump against, that those outflow valves have to open and your ventricles have to push against that pressure. So your heart likes 60 to 80. It likes pumping against that pressure. If your diastolic gets higher, the heart has to pump out against higher pressures. So what we're looking at with afterload are your vessels dilated or are they vasoconstricted? You can imagine that a heart has a hard time pumping into the vasoconstricted vessel or into the vasodilated vessel. If you have to fill up a sewer pipe, which is a vasodilated vessel, you've got to pump a lot to fill up that sewer pipe to get a good pressure, right? If you have a high pressure, you're pushing really hard against a lot of resistance. So the blood pressure doesn't really tell you how good your heart's doing. Your blood pressure there, when we look at that diastolic number, that is basically telling us the size of the vessel that the heart has to pump into. And that is our afterload. So a constricted vessel, what do you think your diastolic's going to be on a very vasoconstricted vessel? Any ideas? What would your diastolic blood pressure be on a vasoconstricted vessel? Definitely higher than 80, over 90. When we start having our systemic hypertension, that is because that vessel is constricted, so it's high. What is a vasodilated diastolic blood pressure going to be? If your blood vessels are super dilated, let's say you were out running and you're flushed and you are massively you just got out of a hot tub, what is your diastolic blood pressure? Exactly, it's under 60. We have seen patients, and we're going to be talking about septic patients. Septic patients have massive vasodilation that are inappropriate dilation. Sometimes their diastolic blood pressures are in the 30s. And that is a picture of a very dilated vessel. So this will give us some data as to, and a lot of people are like, oh, they're just worried about that systolic pressure, 120s, 90s. We want a good systolic pressure. But everyone forgets that the diastolic pressure is really what the heart's pumping into. So the heart likes to pump into 60 to 80. That is a good number for it. But anything lower than 60, if that diastolic blood pressure, if that vessel is vasodilated, it has a lot of work to try to fill that vasodilated vessel. And if it is too constricted, it has a lot of work to pump out against a lot of pressure. So we don't like high diastolics for that reason. And that's why when we're monitoring your blood pressures, your doctor's like, I don't really care what your systolic is. I want to know what your diastolic pressure is, because we're worried about damage to the heart. The doctor is worried about constant vasoconstriction, constant high diastolic pressures causes the heart to push against a lot more pressure. So that's why when you go in, if you've been, did somebody pop in? I just wanted to make sure.
I have a question on this. This is Jenny.
Go ahead.
So when you're talking about vasoconstriction, are you talking about the heart?
Good point. No, I'm talking about your arteries.
Any amount of any of the vascular system. Are we just talking about the heart?
We are just talking, when I'm talking about afterload and vasoconstriction and vasodilation, we're talking about your arterial system. So mostly your aorta and your arteries.
Okay.
I'm not talking about the cardiac vessels at this point. We're talking about when your heart pumps out, it pumps out into one artery called the aorta. And so we're looking at that vasoconstriction. When you take your blood pressure, you are reading the blood pressure of the of your, what is it, the brachiocephalic artery. You're looking at the artery. You are basically reading the pressure in the artery in your arm, which is directly off of the aorta. It's one of the, so you're looking basically at your blood pressure that you take in your arm. And that's because we can't really take a blood pressure in your aorta. You can with invasive materials, but you can't take a blood pressure of your aorta. So the closest blood pressure we can get is in that arm, and that is really what we're talking about, is the blood pressure in your systemic arteries. Does that make sense?
That helps.
Okay. And, your cardiac arteries are arteries as well, but really, we're not really talking about the cardiac. I'm talking about that they are trying to pump into the aorta, and since we don't have an aorta blood pressure, really just our regular blood pressure in our arms is what we're talking about. So when you are looking at your diastolic, maybe you'll have a newfound respect for diastolic blood pressure. That is a very good indicator of vasodilation or vasoconstriction of your arteries. This has nothing to do with your veins and what your veins are doing. This is all about your arteries because we pump into the arterial system. So a lot of times, to really oversimplify things, we talk about preload being the venous system and afterload being the arterial system. Any other questions before we move on with that? So I want you to hopefully avoid, on all of your cardiac patients, we really try to avoid vasodilation and vasoconstriction because both cause stress on the heart. We want them to be right in that normal blood pressure range. And there's just another picture that will tell you kind of normal 60 to 80, vasoconstriction, high resistance, and vasodilation, low resistance. Both of them, both abnormal conditions, cause the heart to pump harder because in vasoconstriction, we pump into that teeny tiny hole. You got to push stuff in there. And with vasodilation, we have to pump more to try to fill that hole. Okay? So that's a concept of afterload. And then we actually have the heart strength. So someone mentioned earlier ejection fraction. And that is a pure measure of the strength of the heart. How strong is that heart pumping? And this is where we start looking at peripheral pulses, skin warmth and color, cap refill. These are our measures of, is the heart pumping hard enough to perfuse our periphery? A weak heart cannot pump strong enough to get blood all the way out to our periphery, and we start having weaker pulses. We start having pale skin. We start having prolonged cap refill. If we have advanced monitoring, we can measure ejection fraction or cardiac output. Those are direct numbers that we can get. I usually put the assessment pieces because you're not planning on, unless you're working in an ICU with advanced measurements, we usually only have our assessment values. So I like to divide them up. That for measuring preload, we have edema, we have JVD. If the preload's getting really, really high, we have JVD. But really, we only have edema and urine output to measure our preload. And then we have, for measuring our afterload, we really only have our diastolic blood pressure. And for measuring contractility, we have our pulses, our skin warmth, and cap refill. That is telling us that our heart is adequately pumping out. Now, someone can say, well, if you have decreased afterload, or let's say you have a massively vasoconstricted vessel in your legs, you might have bad pulses. That's true, but we will also have a very high diastolic blood pressure as well if they have massive vasoconstriction. We usually prefer to pulses, skin warmth and color, and cap refill as indicators of the strength of our heart pumping. Because if our heart is doing a good job, we can get blood flow squishing out to the extremities. If our heart is failing or weak, we do not get blood flow out. Now, all three of these do go together. Of course, when you have a dry patient with low preload and the heart's pumping its little fastest trying to get blood out to the periphery, hopefully we're getting blood out there, but you can have, if you don't have enough blood flow, the heart just doesn't have the strength to pump out no blood flow. But these are general concepts and how that if you can have a patient that has a preload of 18, like a CVP of 18. They've got tons of fluid, but you have clammy skin, bad cap refill. That's because the blood has never made it through to get pumped to the extremity. So something is wrong. It will tell you that your heart is not that strong. You can have a CVP or a central venous preload pressure of 18. That's super high, right? We should have tons of fluid volume circulating around. But we have a high CVP and we have bad pulses. We have cool, clammy skin. We've got no good cap refill. What's the damage is the heart. The heart's not getting that high preload out to the afterload. Something's wrong with the contractility. Does that make sense to people? So we look at all three together to make sure that our heart is working. We can't get in there and just measure our heart. It's very hard to measure our heart. We have to look at all three: preload, afterload, contractility. So let's say you have a hiker that is healthy as a horse, no problems with their heart at all, and they come in and you have a CVP measurement of 2 and no good pulses. They are cool, clammy, diaphoretic with large cap refill. Did their heart die? Are they having a heart attack? Are they in heart failure? No, you can say, all right, my pulses and my skin warmth and color and my cap refill are bad because I don't have any fluid to circulate. I have no urine output. I've got a dry patient, so probably not my heart. Now we have let's say a COPD exacerbation patient come in. Kind of an older gentleman, COPD exacerbation, having trouble breathing. Now this patient has peripheral edema, jugular venous distension, cool, clammy skin, bad pulses, prolonged cap refill. What is going on with this patient? Probably a weak heart, probably heart failure, because we have a ton of fluid in the system. I can see it. It's leaking out of his tissues. It's sitting in his jugular vein. We can see it, but it can't get through out to the body. The pump has failed somewhere along the line. So really, we have to use all three together to give us a problem with the heart. Once we have a problem with the heart, then we can delve a little bit further into how to assess what the problem with our heart looks like. But just seeing those two different patients, you can discount just because you have bad pulses, bad skin cap refill, that sort of thing. You kind of have to look at the other side. Is that because we don't have blood flow, or is it because blood flow is backing up and not getting through the heart? So you have to use all three of these concepts. And this is just more assessment. I am going to point out to you again, in case Professor Collins didn't point out to you at the beginning, do not ever chart no pulse. Please don't ever chart no pulse. If your pulse is absent, you have to use a Doppler to confirm that, because a pulse of absent is really, really bad. We don't want to have a pulse of absent. So definitely use a Doppler to double check your pulse. There are a couple of different pulses that you can feel that you probably haven't talked about before. Pulsus paradoxus just means that when you take a breath in, your pulse diminishes. Like, so it's strong, 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 weak, 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 strong, strong, but it goes in a pattern with your inspiration. I might have to hook up my, I have a pulsus paradoxus just as a normal finding, because I like to think of myself as tiny. Tiny people generally could do this because when your lungs are full of air, what is happening to your heart? Think about your chest cavity. It's basically a walled-in cavity. And when you fill lungs full of air, a big, deep breath, we kind of squish the heart a little bit. There's not a whole lot of room. And so people can have a pulsus paradoxus because basically on deep inspiration, you actually squish the heart and so it can't pump as strongly. And you can see it. I'll see if I can hook up my, when I do my little, I don't know, my Samsung Fit, I can show pulsus paradoxus because when I take a deep, deep breath, my cardiac ejection fraction goes down because the heart's a little bit squished. It is not normal if you don't normally have a pulsus paradoxus, and now all of a sudden you do. When you have rhythmic, basically heart decreasing, and that's that second picture here. This one is pulsus paradoxus. This just means that when you breathe in, you can see how when they're doing deep inspiration, they're not pushing out. This is actually, you can see this on a pulse oximetry. When you're reading a pulse oximetry, you're seeing, if you have a good pulse oximetry reading, you can see how strong the beat is to that finger. It's reading the pulse of your finger there, your extremities, and you can see that when you take a breath in, you're not beating as strongly out to that finger, and that's because the heart got squished a little bit. Pulsus alternans is where every other beat is weaker than the beat before it. And that is not a normal finding. It's not related to your inspiration at all. If it's related to inspiration, we kind of blow it off. So just in case you hear pulsus paradoxus, pulsus alternans, and we'll talk about it a little bit when we talk about tamponade. A respiratory sinus arrhythmia, yeah, it could be respiratory sinus arrhythmia because basically it's just that your heart's getting squished when you take, there's just not enough room for your lungs and your heart to be doing everything perfectly. So that one is not nearly as bad of a finding, but I just kind of put those there so that you know what they mean. And I think that might be it for, we have a couple of labs that I have highlighted for you. Troponin, you probably already have heard of all these, but these are the ones in bold are ones that I'm probably going to use for testing purposes to help you recognize cues. Your troponin, if it's greater than 0.4, that is a sign of actual heart muscle damage. This enzyme is only found in heart muscle, and it does get elevated within a few hours of heart damage, and it usually peaks in the first 24 hours after a heart attack. So it's very specific to heart muscle damage. So know your troponin. I know there's like the CKMB and the CKs. Those are not as specific. The CKMB is specific to the myocardial muscle. But the troponin is much more sensitive. So we usually use the troponin to measure heart muscle damage. The BNP is going to be a measurement that I really want you to get to know for cardiac patients, and is probably our first test coming after that COPD guy that comes in. I see he's got peripheral edema. I see he's got jugular venous distension. I see he's got weak output. I'm worried about that heart. We'll probably test his BNP to see if he has any kind of heart failure. This is a enzyme that is released as the heart gets stretched, and so a BNP is correlated to heart failure. So a BNP greater than 500 is defined as heart failure. I've seen patients with a BNP of 10,000 before. So that is a patient that's got very, very, very severe heart failure. Someone mentioned ejection fraction. That is an amazing indicator of how strong your heart is. In fact, probably the best indicator of how strong your heart is. But we can only read it on a cardiac echo or by cardiac catheterization. Not as easy to get. You have to get a specialized test to get your ejection fraction. But with patients with any kind of heart failure, I will always ask you to look for their BNP numbers and their ejection fraction numbers. Because if they have heart failure, they probably have been diagnosed with an echo that has an ejection fraction less than 40. So if they have heart failure in their history, they probably have an ejection fraction documented somewhere in their chart, and that would be something that we would want to know. The lower the ejection fraction, the worse the heart failure. We've had patients with ejection fractions of 10, which means that they're only ejecting 10% of the blood in the ventricle. The normal is 60 to 75. We never empty our ventricle out, just like when you empty out a sponge. If you wring that sponge with all of your strength, you still won't empty out the sponge. There will still be fluid left in it. And that's what happens in the ventricle. We're trying to just get at least 60 to 75% of the blood out to the body, and that is normal. But if you're only ejecting 10% of the blood that gets into the ventricle, that is a very, very weak heart and a very bad ejection fraction, and will tell you a lot about your patient. So I always ask you, if your patient has heart failure or you're suspecting heart failure, see if a cardiology consult has been done and see if they have a BNP and an EF. Those are great ways to quantify how bad your heart failure is. And then CVP, if they do have it, those are the two, we've got a preload and afterload numbers there. Our contractility number is going to be our ejection fraction. So preload central venous pressure, afterload diastolic blood pressure, and contractility is going to be our ejection fraction if we have those numbers available. So I think on that, on this, we're going to take a little break. I'm going to give you about 15 minutes to go get more coffee, go to the bathroom, all that stuff. And this, I'm going to leave it on this slide for a minute because we're going to go into all the other stuff after break. So I'm going to leave it on this slide. I will be around if you have questions, but take a break till, what time is it? 10? Let's come back at 10, let's like 10:25. We'll say 10:25. And if you have any questions, let me know. Otherwise, I'm going to mute up until 10:25. All right, so we kind of covered all of our concepts, and you have a pretty good knowledge now of the basics of normal heart. We got the right side, we got the left side, you know what's happening during rest, you know what, when you hear lub, it's basically the end of diastole, everything's getting ready to switch over, outflow valves are opening, AV valves are closing, we eject out to the heart, or out to the body, and then everything closes down, we hear dub, and we're going back into diastole to do it again. So basically, lub dub. We've learned lub dub. We've learned how everything flows through. We've learned the valves that are open and closed during each time. So you're like, I'm ready. I got how this heart works. I know how to do this. So let's keep moving, and we will talk about how to monitor it. If it lets me move forward. This is going to be one of those things where it... Okay. So, continuous EKG monitoring. Again, this is where you probably have had this somewhere in your past. That continuous monitoring, we can monitor through 3 or 5 leads. I do have a picture of where everything goes. Continuous monitoring can either be direct to a monitor or it can be telemetry. Telemetry just means it's got a remote box. So whether it says continuous ECG monitoring or telemetry monitoring, they are the same thing. Telemetry is continuous ECG monitoring as well. It's just got a remote readout, so the patient can be free of the monitor. But they both are set up the exact same way, and they both read continuously. The rest of the exams do not read continuously. They're a one-time exam. We have the 12-lead EKG, so not continuous. You can't get a 12-lead EKG to read continuously. It's a one-time snapshot of the heart. Echo, you can do those at the bedside. We have the guy sitting there doing the echo here. It's just an ultrasound. It's just an ultrasound. You can do it at the bedside. They can do them in the OR. The TEE, the transesophageal echo, is one where they actually put a camera, the ultrasound probe, into your esophagus and look at the heart from the backside, basically. So that's a transesophageal. They're actually putting the ultrasound probe into your esophagus and then kind of looking at the backside of the heart. But most commonly, it's just a regular echocardiogram, and it is an ultrasound. You can do hemodynamic monitoring, which we will talk about in a little bit. Arterial line is reading a constant reading of your blood pressure. CVP, we've talked about, is a continuous reading of the central line. You need a central line to read that. And then you have a pulmonary artery pressure, which is very, very highly invasive. We talk about all 3 of those when I do the hemodynamic section. You can have exercise treadmill testing. You can have electrophysiology studies, cardiac catheterization. So this is kind of least invasive to most invasive list of things that we can do to diagnose it. But you can see that most people probably with any kind of heart failure has had a 12-lead EKG and an echocardiogram. Those are the least invasive, easiest to do, and give us a lot of data that we sometimes don't even need to move forward to the rest of them. But they are there. So those are just some exams in case you hear the words bandied about the exams. Here, in case you did not get it somewhere in the past, this is kind of a review of how to hook up your leads. 5-lead just reads more leads. And when we're reading multiple leads, I'm not going to need you to read multiple leads on an EKG, but just know that really the size, whether the lead reads upside down or isoelectric or right side up, really high, depends on where we're basically, those electrodes are reading electricity. The closer the electricity is to the electrode, the stronger the amplitude's going to be. So you may see, if you go to clinical, you may see your nurses switch the leads around or redo leads to try and get a better reading on the EKG, because we're just trying to read electricity. And basically, the closer you are to your electrodes, the better the electricity you read. So, you can hook up 3 leads, you can hook up 5 leads. They just give you more information, and they're just double checks on each other. And you probably don't, I'm not going to test you on how to put on leads, but it's good to do that if you are in clinical and you're getting an admission or something, that you can go in and put on some leads. So I'd like you to kind of just look those over and just know how to hook up the continuous EKG monitoring. And this is the same for telemetry boxes or a continuous monitor, whether you're in the ED, in the ICU, or on the tele floor. If you're putting leads on a patient, it's the same placement for any kind of EKG reading. The 12-lead EKG, again, not continuous. I've had a lot of people in SIM who are like, oh, let's hook them up to the 12-lead. You can only get a snapshot, like a 6-second snapshot of what the heart electricity is doing in a 12-lead. We do not leave them on and run continuous paper off of a 12-lead. And this just basically has 12 electrodes rather than 3 or 5 electrodes, just giving us an idea of more of the electricity. And the more electrodes you get, the more readings you get, and you can see more about the electricity going on around the heart. You will not be reading 12 leads in nursing school. I don't think that is a base nursing school concept. If you want 12 lead EKGs, though, I do have a very simple PowerPoint to go over it, and I could do a supplemental class if people are interested in 12 lead EKGs. So people who maybe already work on tele, people who want to do ICU, I will probably, advertise like a separate time outside of class if you want to come to a 12 lead reading class. But there will be no test questions on 12 leads. I just don't believe that is something that you need as base nursing knowledge. There will be no 12 leads on the nursing, on NCLEX. And I do think it's kind of advanced knowledge. So just knowing that a 12 lead is a one-time event and that we get more readings with more electrodes. And if you want 12 lead EKG, I'm happy to give it to you. I do have a version of the EKG class that I used to give at Chandler. So if you want it, I'm happy to give it to you. Just send me an email or a text and let me know that you're interested, and I'll see how many people want to get together for 12 leads. But again, not for our exams. It's extra supplemental stuff. So let's look at a normal. When I say EKG, I'm just looking at a lead 1, lead 2, lead 3, just a regular cardiac tracing. And we're going to learn how to read EKGs. Did you do this in block 2? If you were here in block 2, I think some of you came in block 3. I know, Ashley, you got in here just at this block. Are we assuming that everybody is basic? Like nobody was like, oh, yay, I know everything about reading EKGs. All right, very basic. Okay, and this is going to stay very basic. Remember, we're going to talk about normal before we talk about the abnormals, which we will go into next. This is your EKG broken down very slowly. That basically the P wave, and I put these pictures here so you can see that the P wave is electricity moving around the atriums. Okay, so our P wave is atrial electricity. This is starting in our pacemaker nodes. The SA node is our pacemaker node. And the AV node, hey, it's AV, atrial ventricle. It's sitting there at the basis of, this is the SA node is generally at the top of the heart. And these are known as our pacemaker cells. That's the SA node. The AV node is down here between the atrium and the ventricle. And that's where the electricity kind of recollects before it goes to stimulate the ventricle. Electricity moves before the muscle contracts. So your P wave is electricity moving around the atrium right before the atrium contracts. So you have to have a stimulus to get muscle contraction. Any cardiac muscle can be a pacemaker. Even though there's cells in the SA node that there's a pacemaker, and those are usually the ones that control everything, I can tell you that this little guy here may get a wild hair up its butt and start a cycle. A cell down here in the ventricle can get a wild hair up its butt and start sending electricity. All cardiac cells have the ability to send out electrical signal, and that's where most of our arrhythmias or dysrhythmias happen, is when the signals don't come from the SA node. We really want them to come from the SA node. That's the normal function. But like I said, when you give privileges to a whole bunch of people, some people will mess it up. And every cardiac cell has the privilege to start an electrical charge. And when we get random cells doing random things, they kind of butt into the system and mess the system up, which is basically the basis of an arrhythmia, is just a wild hair electrical cell doing something outside of the normal system. The normal system is SA node goes, sends the signal around cleanly, it collects in the AV node. So while the signal waits in the AV node, we have a space called the PR interval. The P wave has already happened, and we have this little waiting period, and that's when the atrium contracts. So we have contraction during the flat parts of the EKG. So the P wave happens. That means that everything has signaled around let's see, is there any time difference? Hang on, let me just move this little box out of the way so I can read the question. Is there any time difference between the SA signal getting to the left atrium compared to the right atrium? Yes, there's not much of a time difference. You can see that it goes around to both atriums kind of at the same time. Not a huge amount of time difference, but if there is something you may see, and this is getting kind of advanced, but instead of a nice P wave like this, you will see a notched P wave like that. And that's kind of showing you that there's extra time during that conduction of that P wave. Again, you're not going to notice something like that. That's not even noticed by a lot of us, but there isn't a giant time difference as far as you're concerned. What we are seeing here is just general all electricity getting conducted around the atrium. So what we are concerned, though, is that contraction happens during these flat times in the period. So when you're seeing a pulse on your EKG, that's electricity moving. That system that's been stimulated will contract during the flat parts after the electricity is done moving through. So after our P wave, we have atrial contraction, and then we go into the QRS, and the QRS is just a map of watching the electricity flow through. So what happens is usually there is an EKG. Let's draw my little, let's say there's a EKG reading here, there's an EKG, there's an electrode here, and there's an electrode here, if we're looking at our chest. Usually we are looking at lead 1 or lead 2. So if we're looking, this is a receiving lead. So let's say we're looking at lead 2, which means this lead is our eyeball. All right, it's looking at the heart. All right, that is what those leads do, is they just look for electricity. So as this electricity comes at the eye, so if we have our little eye over here, as this electricity comes at the eye, it sees it getting stronger and the wave goes up. Then as the eye is watching this electricity, then the electricity starts to go away from it as it moves around, and you'll see it go down. So wherever your little eyeball is looking is what you're gonna see this electricity do. So as it comes down the heart towards the eyeball, you see it go up, and then as it moves around back up around the ventricle, you see it deflect down. So we're seeing a picture, that QRS is seeing a picture of that electricity moving through the heart. And that's why normally our QRS is right side up. Let's just say that's looking at, this is the one that reads lead 2 here. Let's go back and draw our eyeball in a different place. Let's draw it here. This is lead 1. So this is now our eyeball. And if we are reading it in lead 1, let's see what our eyeball is going to see here. So it is looking at the heart this way. Is this going away or closer to the eyeball here? This is moving away, so what we are going to see is we're going to see it look like it's going down, and then as it comes back up this way, we're going to see it come back up. So this is what it looks like when the QRS is upside down. It's really just that you're looking from it from a different eyeball. So you switch it on your monitor to read lead 2, and then it goes right side up. So no matter if your EKG is upside down, just switch it to a lead where you're more comfortable reading it. And that's why a lot of people are like, oh my God, what happened to the rhythm? All that happens is that you changed on the monitor where your eyeball is. So when you're reading all these things, and I think this one is lead 3 here, and if you're reading into 5 different leads, you can have, eyeballs all over the place. You're changing basically what side of the heart you're looking at. And that's a complex thing. Whenever we give you a rhythm strip to read, it's going to be probably lead 2, the one that's very commonly, and lead 2 is the one that most people will show rhythm strips in, because that's the one that is the most common rhythm. So will the QRS ever be upside down in the black lead, or will the QRS be upside down in the black lead position? It shouldn't be. It shouldn't be, because electricity should always, so let me think. Let me look at, black lead is lead 1, because we have, so this one is, here, let me draw our, this one is usually, this is the black lead. This is the white lead. Oh, well, I guess it's not going to show up. This is the white lead here. So I'll just draw this one here. And this one down here is the red lead. And if you have 5 leads, then you have an extra, you have a green lead down here, and you have a brown lead right in the middle. So the black lead is usually, this one's lead 1, this one is lead 2, this one is lead 3, this one is lead 4, and then the one in the middle is usually brown, and it's lead 5. And so, yeah, it usually, when you are looking, most heart rhythm, most heart electricity runs this way, which is why lead 2 is the most common, and we see an upward QRS because of what's going on. And again, I don't need you to be able to read different reads. I just want you to not freak out when you see a QRS upside down, or what they will call isoelectric. Let me go back and show you the little, oh, we went too far the other way. When we look at this screen here, do you see how this one has half of it up, half of it down? This one's got it all the way up. It's just the way that it is kind of looking at the rhythm. And so nothing is wrong with these rhythms. You just have to know which lead you are in to know whether the QRS is supposed to be all the way up or all the way down. So this one is a little bit isoelectric. It can be upside down, and it depends. If you have the leads mixed up, and I think I drew my leads the wrong color because I don't know my right from my left unless I'm looking at my patient. But, you know, I just want you to know that different leads have different tracings, and to not freak out about it. And if you really want to read just your standard typical EKG with all uprights, P's, and QRS's, it's best to read it in lead 2. Does that make sense? Just make sure when you're in clinical or whatever that you're in lead 2, because if you're in lead like AVF or something random, your EKG is going to look different. And that's okay. Just switch it back to lead 2, or ask your nurse to switch it back to lead 2, or look at it in lead 2, and you will see what it's supposed to look like. And that's what we're showing you, and we show you all these rhythm strips, is usually they're in lead 2. But if you see something weird or a strip that doesn't look normal, it's probably because they have it in a different lead. Maybe it wasn't reading well in one lead, or maybe they wanted to see something different. They wanted the eye to be placed in a different way. So anyway, QRS just means that it is moving around the ventricle. So after it moves around the ventricle, it stops, and then we have contraction, and contraction is happening in the ST interval. So you have your P wave, then you have a space where contraction happens, then you have your QRS, which is electricity moving around the ventricle, and then you have the ST interval, which is where your ventricles contract. And then you have the T wave, which means everything's repolarizing, and it's just kind of like a bunch of junk kind of resetting. Which is, the T wave is important only in the fact that if you get stimulated while things are resetting, things can go bad. So the QT interval is basically the whole time that the ventricle is busy, conducting, contracting, resetting, and so that's the amount of time that we're, really in our systole. And the rest of the time we're in diastole. So that ST segment there, that ST, that little flat area, is where the ventricles contract. That PR segment, that flat piece there after the P wave, is where we are contracting our atrium. The QRS is just electricity moving around the ventricle. So remember that electricity comes before contraction. We contract after the electricity moves around. So we should have a P wave, we should have a QRS, And you should have a T wave. Sometimes T waves show up, sometimes they don't. They're hard to see, but it just means resetting. So let's just look at EKG paper so that we can read our timing of all of this, because when our timing gets off, we start having arrhythmias and things aren't working quite right. So we're going to read our timing. So we're looking at this EKG paper. All the strips I'm going to give you, if I give you a test, are going to be 6-second strips because that is the standard. The standards are really lead 2 and a 6-second strip. When you just print something off of a monitor, it's going to give you a 6-second strip. And it's usually going to report to you in lead 2 because that's our standard lead. The teeny tiny box, so when I say the smallest square, I am talking about, oh, I don't even know if I can draw this. That is the smallest square. That is a 0.04 seconds. It's really teeny tiny. And I don't have, God, we don't usually have enough time. I don't have good eyesight to measure that kind of thing. So we generally will look at the larger square, which is this guy here. Not really that much larger, but it's a larger square, and that's 0.2 seconds. So I will call them small boxes, large boxes. There are 5 small boxes in each large box. So if I go from this dark line to this dark line, that's 0.2 seconds. And then once you go to these 5 larger squares, if you get all of these together and get 5 of them, you've got 1 second. So you can tell there's 15 large boxes in these 3-second intervals. And there will be 30 large boxes for a 6-second strip. So when I'm saying small boxes and large boxes, that's what I'm talking about. And on a 6-second strip, the reason 6 seconds is standard is you take the number of QRSs and multiply it times 10, and that's your heart rate. So when you get a 6-second strip, which all of yours will be, all you have to do is count your QRSs. 1, 2, 3, 4, 5, 6, 7. Oh, I didn't mean to do that. Go back. 1. Ugh, Lord have mercy. See, when I try to draw, I get all kinds of crazy. Okay. So 1, 2, 3, 4, 5, 6, 7. And we multiply that times 10, and your rate is 70. So a 6-second strip is standard because it's easy to multiply times 10. Just count your QRSs, multiply times 10, and that is your heart rate. Normal EKG analysis, there's 6 things to look at. And I'm going to do these 6 things on all of our strips. First, count the rate. So on this one, let's go ahead and count the rate. We've got 1, 2, 3, 4, 5, 6, 7, 8. So our rate is 80. Is there a P wave before every QRS? There's one, there's one, there's one. So you're like, wow, this is amazing. Yes, there is. That's normal. The next thing we're looking at is the size of the QRS. Is the QRS narrow? That is what normally is. 1 to 3 small boxes. So I would have to blow this up. Let me see if I can blow this up without... I don't think I can blow this up very easily without getting rid... I might have to get rid of my buttons. I want to just make you big. Can I make you big? Let's see. Oh, I can make you big. Yay. That's as big as I can make it. All right, so this QRS right here, I don't know if you can see this, but when we measure the QRS, we are measuring right there. We're measuring from the Q, which is where this thing begins, up R, and then all the way back down to the S. It's 1 box. It's teeny tiny. It really should only be 1 to 3 small boxes. That is normal for a QRS. And that's what we're looking for, is just that it is normal looking. Let me make this small again. So, just let me get this is back to normal. So when we're looking at QRS narrow, 1 to 3 small boxes. Now you could memorize seconds if you want, but I think it's easier just to remember 1 to 3 small boxes and know what a small box is. And you can kind of just guesstimate. Nothing's a perfect science. But if your QRS is less than 3 small boxes, it's narrow and normal. Okay, narrow is normal. Regular is when we measure our R to R. So that's just the tips. So remember, if this is Q, this is R, and this is S, and this is Q, and this is R, and this is S. We're going to be measuring in between, and you can really just take, I like to take a piece of paper and just mark my 2 peaks, and then see if all the peaks are the same, and that is regular. So a normal rate should be 60 to 100. There should be a P wave before every QRS. The QRS should be narrow. It should be regular. And then we have some more checks, just to double check everything. The PR width, if we're looking at, we go from the beginning of the P wave to the tip of the R wave here. This PR width here should be 3 to 5 small boxes. So it should be like basically 1 large box. If we are getting longer, that means that it's taking longer to conduct around the atrium, and that could be a problem. So we're going to look at that PR width, and then an extra additional, which we don't usually do, is the QT width, which is basically from the beginning of the QRS all the way to the end of the T, and that's measuring the whole systole cycle. So from beginning of ventricle conduction to resetting. We only really look at QT width for certain medications that prolong it. Because if we're prolonging our whole systole and reset period, there's much higher likelihood of a misfire during that time. So we're not really going to look at the QT width very much. So we really only have 5 things to look at. First, get the rate, no matter whether it's regular or not, just get the rate. Then look for P waves before every QRS. If there aren't, we'll talk about what to do with them. Look for your QRS being narrow, look for it to be regular, and look at the PR width. And we do this with every single abnormal arrhythmia, and so you'll get to know these 5 things, and we'll be able to recognize your abnormal width. But I just wanted to show you kind of what we were talking about when we talk about all that different, what we're reading. All right? And then this is putting it all together, all the concepts that we went over, what the blood is doing, what the P wave looks like. So in diastole, you are having a P wave, basically. A P wave means you're in diastole, the AV valves are open, the ventricles are filling, the outflow valves are closed because there's no contraction going on. We are filling during diastole. The deoxygenated blood is in the right side of the heart, and on the left side of the heart, the oxygenated blood is filling. Does that make sense? So right side and left side are both filling during your P wave, during diastole. Then we have our snap shuts. The AV valve snaps shut, the outflow valves opens, diastole has officially ended, we are getting ready to eject. When we are getting ready to eject, the QRS is happening. Because during systole, during ejection, we are actually in an interval. Okay? During systole, and you can see how short systole is. It's so short. It's just your QRS and your ST interval. That's it. We spend most of our time, our heart is in diastole and filling. Systole is only 1/3 of the cycle. 2/3 of the cycle is diastole. So systole is very short. It's just during the time it takes you to get a QRS all the way to the T interval. And that is systole. And then we have during our T wave, everything's resetting to fill again. So we have learned how this heart works, and now you know where everything's going, and you are heart masters now. Do you want to take a break before we go through hemodynamics? Break for lunch, or finish this one and then break for lunch? Ideas? Thoughts? Let's finish. Okay. Let's go through here. All right, finish then break. There's not that much left. I am just going to point out some hemodynamic monitoring devices. When we talk about hemodynamics, we are reading anything more than, we're basically starting to do invasive readings. Okay, this is not just a blood pressure and a heart rate and things like this. We are actually connecting lines to a monitor to read something from an invasive IV. So when I talk about hemodynamic monitoring, we're talking that we have put an IV in and we are connecting something between the monitor and that IV to read a pressure. I'll let you read through it, who needs it and why. But because every single hemodynamic monitoring device requires an invasive line, we kind of want to limit. It becomes an invasive thing. So we don't want to measure something hemodynamically if we can do it without. So that's why I gave you the assessment parameters for preload, afterload, and contractility that we can do without a hemodynamic device. So if we're ever doing least invasive to most invasive, hemodynamics is a pretty invasive thing because it needs a line. If it's a central line, you're at high risk for pneumohemos, vessel damage. There's just a lot. And also your nurse has to be trained to read it appropriately and know what waveforms are actually believable or not. There's a lot of interpretation in the hemodynamics in that, just like with a pulse ox, if your pulse ox is not reading a nice, clear pulse waveform, you can't believe the number that it's giving you. And that's something that treating a single number is no good, and treating bad waveforms is no good. So there is a lot of risk when we get these hemodynamics that you need to make sure that the nurse is trained to do it. So, of course, you're not going to be trained to read them perfectly, but I want you to know what they are. And I will do this setup tomorrow. And again, I'm not going to test you on the setup. I just think this is important when you go to clinical. If you haven't had your hospital day yet, and if you did have your hospital day, maybe you got to see some of this. If you haven't had your hospital day, this will help you understand it a little bit better. You have the IV line is number one. It could be arterial, it could be central venous. You have a set of fluid-filled tubing. And then the magic all happens at this transducer, this magical piece of engineering that I don't even know how they put it together. The transducer takes the signals that come through the saline-filled line and turn it into an electrical signal that goes to the monitor. So the transducer is the heart of this hemodynamic monitoring system. We also have a pressure bag, and all the pressure bag does is keeps the fluid in the line and keeps blood from backing up in the line. And then there's the cable that connects the transducer to the monitor. So to get a hemodynamic monitoring device, first you need an invasive line. Second, you need a transducer and some pressure-filled tubing. And I will set that up for you tomorrow or next week so you can see what that looks like. But let's talk about the three most common ones. And I'm really only going to hold you responsible for the central line, the central venous pressure. So a central venous pressure you can put on any central line. All you're doing is you're hooking that transducer and tubing to one of the ports of your central venous line. It can be a PIC, it can be a line, in the internal jugular and the subclavian. You can hook it to any peripheral line or any central line, and it will read. And you can see where the tip of this little guy is here. The tip of it is either in this vessel, and sometimes it's all the way into the actual right atrium. So it is a measure of preload. It's going to measure this area and the blood returning to the heart. It's probably the most common hemodynamic measurement because it's kind of hard to tell whether you're fluid overload or fluid depleted just by your assessment factors. And usually by the time we see the assessment changes, they're probably pretty overloaded or pretty dry. So sometimes this is the most common quick thing that we could do. They already have a central line for probably fluid or something, and we can keep an eye on what we're doing. So you just the transducer tubing and cable goes to any kind of central line to read the pressure in the veins. And this is going to be used to monitor our fluid replacement. If we are shifting fluid for any reason, we talked last semester about giving, 3% saline or hypotonic, hypertonic solutions. This is just that we don't have to wait to see the changes in our edema and things like this. We can get a quick reading of what's going on with the pressures in our vein returning to the heart. Would there ever be a time to have both a CVP and arterial reading? Very often. Yes, because the arterial reading is going to tell us about our afterload. The central venous pressure is going to tell us about our preload. So many heart patients have both, or even patients who are trying to balance out both. Because as we all know, our arterial side, our arteries, will constrict and vasodilate to maintain a decent blood pressure. So we can kind of tell a little bit of what's going on a minute-by-minute basis by looking at both. If our CVP is high and our blood pressure is low, we know there's something wrong in the heart. If the CVP is low and our blood pressure is high, maybe there's a lot of vasoconstriction going on. We have to look at both of them to really see the full picture. So yes, there are many, many times we have both. So that's the central venous pressure. Hook it up to any central line, and you get a CVP reading. The next one, and this is kind of what a CVP waveform will look like, for the crazy OCD nurses. Usually the blood pressure line is in red and the CVP line is in blue. We really like our color coding. Blue is a color for CVP mostly because it's returned to the heart. It's venous pressure, so it's blue. Arterial pressure is red because it's oxygenated. We love those colors. But anyway, so what we're looking at on this monitor is the CVP reading. Well, one, it's labeled CVP here. But what you are seeing here is this is a waveform for your pulse, basically. This is right here, your artery. So when your heart ejects, this is your systole, and your diastole is the low one. But this is when the heart ejects out, you get a high pressure, and then it kind of staves off. And your heart ejects out, and then it kind of drifts off. And then your heart ejects out, and then it drifts off. So you can see that this is a little bit before your heart ejects because this is blood returning to the heart. So the pressure is higher before the heart ejects because this is return. So you can see if you lined these up that the CVP becomes before the artery. And it usually is, like I said, you can just kind of see. But it's also a much smaller number. It's very lower. It's not red as a systole over a diastole. It's just an average. And what the number here, this 15, which we all know is that a high or a low CVP? What's our CVP of 15? It's a high CVP. Oh my gosh, this patient's pretty fluid overloaded. So we can kind of look at this patient right now and get some information. Here's his blood pressure, 167 over 69, and he's got a pretty high CVP here. So he's got a lot of fluid returning to the heart. But look at that, we've got a high systolic pressure and a normal diastolic pressure. So are our veins vasodilated? Are they vasoconstricted, or are they, our arteries. Are our arteries vasoconstricted, or are they vasodilated, or are they normal? What do you read from that? They are normal. So this number, the diastolic of 69, means that our blood vessels are adequately open and adequately filled. So we have adequate blood circulation going around. So that means that this patient is fluid filled. They don't need more fluid. Everything is where it should be. They are fluid filled. If we looked at this patient, we could say, all right, they have a lot of fluid. They don't need any more. This would be a patient where I would be wondering, why would we be giving them extra fluid if we're giving them extra fluid? Look, they're pretty fluid filled. They've got a decent CVP. That CVP is like on the overload side. Those vessels are nice and chock full. They are not too vasoconstricted. They're not too vasodilated. And the reason we got a blood pressure of 167 is because we got a lot of fluid circulating around. Those vessels are chock full of fluid. And if that vessel pressure is too much fluid, we are going to have leaking. And if we're going to have leaking, it's going to leak peripherally or into our lung space. So that is a chock full patient right there. I would not put more fluid into that patient, because that high CVP means that that vessel is full to bursting with fluid. Does that make sense? And there's no problem right now with vasoconstriction or vasodilation, because I can look at my diastolic blood pressure and be like, that vessel is just chock full of fluid. It's not because it's vasoconstricted or vasodilated, it's just full of fluid. And that's why our systolic pressure is high. So I can take a look at that patient without even looking at his assessment, if those numbers are believable, and say that patient is chock full of fluid, and I'm kind of worried about this patient at this point being like, if they're that chock full of fluid, if they don't need that much fluid, they could start leaking it out through their capillaries, and they might end up having a little bit of peripheral edema or pulmonary edema being that full of fluid. Make sense? So anyway, that's what we use those numbers for. And this is just an average, basically. It's taking its peak and its valleys, and it's giving you a number right in the middle. And that's what we're looking at on there. So that is basically looking at CVP and how we use it. Arterial blood pressure, the other screen had arterial. What about the kidneys? What are you saying about the kidneys, Jen? I wish we had something to measure the kidneys. Poor little kidneys. Anyway, the arterial line, I'll let you finish in your rest of your thought there. Which comes first, pulmonary edema or peripheral edema? That's a good question. There are more peripheral veins. Gosh, they probably come along the same lines. I'm going to say peripheral edema first, but by the time we notice peripheral edema, there's probably pulmonary edema going on. So if we have peripheral edema, there's a high likelihood of having pulmonary edema as well, because if our capillaries are leaking, they're probably leaking in the lungs too. So just always be on the lookout. But peripheral edema will come first. It's going to try and leak out. There's more peripheral capillaries than there are lung capillaries, and we do have inhalation, exhalation to try and prevent leaking of fluid into the lung space, whereas the periphery doesn't have any kind of pressure against it. So we'll leak peripherally before we do pulmonary. Arterial blood pressure, again, is just, they put in a special IV. This isn't really any different than a regular IV, except that it's into an artery. And it's probably, I think it's about an 18 gauge, but we don't put anything into the artery. Never infuse medication. Medications only go venous. Never infuse anything to an arterial line. It is for monitoring only. So there are no ports that you can inject into, because this is not meant for injections. This is not an IV line. The only tubing to it is kind of a harder pressure tubing, and this is where I would kind of do show and tell and pass around pressure tubing versus IV tubing. Pressure tubing has no give to it. It's more plasticky feeling. It is actually harder plastic, and you are not to inject anything into an arterial line. You may use your central venous pressure. You can use your central venous line, and you can inject anything into central lines, but not into arterial lines. Yes, you can draw blood from an arterial line. So we can draw blood out of this, but we don't put fluids into it. We don't put meds into it at all. It's just for drawing blood and getting a blood pressure reading. You can draw blood out of a central line as well, but you can draw blood from these arterial lines. But don't infuse anything into it. The only thing that you can infuse would be a flush to flush out the line after you use it, but it is not for medications at all. And it is just for reading. And because it's in an artery, it always has to be, if you have anything in your artery, it should be hooked up to a monitor. One, because if it comes out of the artery, you're going to have a lot of bleeding. It's in an artery, and you would want to be monitoring that site. So an alarm will go off if this thing comes out. So anytime anything is in an artery for any reason, we hook it up to a monitor. But we do not infuse anything into an artery. We only infuse into veins. So, and this is just really an arterial waveform. Don't worry about dicrotic notch, but if you want to know, that's basically the end of systole is where that notch happens. And this is basically the blood ejecting out. That's the beginning of systole, and then kind of the pressure drops off until the blood ejects out again. So that's an arterial blood waveform. The pulmonary artery catheter, it does get mentioned occasionally. It's not used that often anymore. It's fallen out of favor, and you can see why. It actually goes through the heart. It is threaded in through the heart, and what it does is we float it in and monitor as it floats in, but it just goes along with the blood until it gets stuck in a pulmonary artery. And then what we do is deflate the balloon, and it sits there and fluctuates in the pulmonary artery. What these lines do, and if I go to the A line, they do the same thing. I'm going to draw here. This is an artery. And what this does is the line just sits in there, and as blood goes by, it kind of vibrates as blood passes by it. And it just reads, and all the transducer is doing is reading the fluctuation of the end of that tube in the artery. And that's how we get the waveforms that we get. So that would happen in arterial line or this pulmonary artery catheter. It is threaded through the heart until it gets stuck in a pulmonary artery. We deflate the balloon, and then it just sits there and fluctuates in the pulmonary artery. So you can see there are high risks of having problems when you have a line in a major pulmonary artery, because you can cause basically a pulmonary embolus if this line gets stuck to the point that it's blocking off your blood flow to your lungs. So we don't usually use them all that often. The only time they're really used at this point is after cardiac surgery. They used to use them in ICU patients all the time to tell all these fun. You can get a cardiac output right there. You can get a reading right from your catheter of your cardiac output, and it will tell you the strength of the heart. They used to use it on septic patients, and it's kind of gone away because the risk is not worth the benefit. And we don't really need to use cardiac output. We've got our pulses. We've got our Euro Swan. This is what used to be called the Swan-Ganz catheter. We have a Foley. We have a urine output. We don't really need all this invasiveness. If we have a CVP and an arterial blood pressure and a urine output, we can tell what our heart's doing without getting an invasive line into the heart. So we're not going to spend a lot of time on the pulmonary artery catheter. I just wanted you to see some pictures of what it is. And these are the waveforms, but I'm not going to test you on the waveforms on it. This is just what we see as it moves through the heart. And if you ever get a chance to see a pulmonary artery catheter inserted, it's actually kind of fun to watch the different waveforms, and you can tell exactly where in the heart it is by the waveforms, because in the right atrium, there's more pressure, it's the CVP pressure. Then as you move into the right ventricle, there's a lot of whip going on because it's a huge chamber with a lot of whip. And then as it moves into the pulmonary artery, it's got higher pressures because it's a smaller space. And then you get a wedge pressure when it's stuck, and that's when you have to delete it. You got to see them put in a PA catheter? Dang, what kind of patient was it? Say now, what kind of patient was it that you got to see it in clinical? Wow. Usually you don't see them put them in, and I only see them really put them in. I don't even see them get put in anymore because I didn't know they were using them. That must be an old school doc putting them in. Either that or they're coming back into favor. I don't know. They went out of favor for a long time. But yeah, I mean, you're putting this in through a, when we were showing you I don't know if I was showing you the central lines. I'll show you next week when I have all my lines in front of me. But you actually, the central line's already in place, and they push this catheter through. And because it's got this balloon on the end, I'll have to show it to you. I don't think the balloon is blown up on this guy. But there's a little balloon on the end, and it floats. And you just kind of push it through, and this catheter is floating through and actually goes through the heart, and you watch it go through the heart. And because, yes, it's going into the heart, for goodness sakes, yes, it is a sterile procedure. Usually they're just put in the OR, and we see them when they come out. So that's pretty cool. I haven't seen one put in an ICU patient in years. So that's pretty awesome. You got a really rare procedure there. But we don't really use these this often, and I'm not going to spend a lot of time on the pulmonary artery catheter. We just get a lot more information about the heart from the pulmonary artery catheter. The thing that you will probably be seeing and could do if you wanted to is we zero and calibrate all of these things, and we zero and calibrate them at the transducer, which is the piece outside the patient. And I will show you this next week. It's not on the test, don't stress about it. But basically the transducer, that outside magical piece of engineering, that electrical piece of engineering that translates the pressure reading from your IV line to a electrical reading for our monitor, that transducer needs to be sitting kind of at the level of the heart. And so we put that transducer at the level of the heart, and then we zero it once a setup, or right after it's set up, or once a shift, or after transport, just basically to make sure that the readings we're getting are accurate and that our trends are accurate. What they do is you lie the patient flat, you put the transducer there, you open up the transducer to air, and it should have no pressure on it because it's open to air, and that's called the zero pressure. Then we close it up and we look at the waveform. Now what they do is, and like I said, this will make a lot more sense when I do the demo next week and I have it all set up. We do have a little flush stopcock on the transducer that we flush a little test of saline through it, and it oscillates a little bit. And we can tell basically whether our waveform is good or bad based on these tests. And if you have an unreliable waveform, you're supposed to fix your waveform, because you can't treat false high readings. You shouldn't be treating false low readings. So we have an extra piece of testing that we have to do, because we can't, just because it's sitting in there, we can't trust it. We have to test it and make sure it's good. And so when we flush these IVs, you will see these extra spikes. So we're supposed to be seeing, when we flush these IVs, just 1 or 2 of these spikes before the waveform returns. If you see that it's looking really high and you're getting really high readings, you flush it through, and if you get a lot of oscillations before it returns to a waveform, you've got what we call a whip. And if there are no oscillations at all, what we call dampened. And if you have a whip or a dampened arterial line or a CVP, then we just know those readings aren't right. Don't treat your readings unless you can fix these problems. So I just wanted to point out to you that, if you hear someone say, oh, we're not, you could have an alarm that's alarming all the time, low blood pressure, and you're wondering why the nurse isn't doing anything about it. And she's like, oh, that A-line's dampened, it's no good. That's what they're kind of talking about. Or if you have a high blood pressure and nobody's stressing out about it, she's like, yeah, I tested that a while ago, it's got whip, we're going to pull it out, it's not working. Because the numbers on the screen doesn't make it right. And so you may see people that you're like, why isn't anybody treating that blood pressure? It's because our lines aren't really reliable. And so we need reliable waveforms. I'm not going to test you on causes and what you do to fix them. It's just information for you. What I do want you to know, though, is what the CVP, where it is, and the normal readings for a CVP, and that you don't push anything through an arterial line. So